Welcome, everyone, and thank you for joining us today. My name is Amanda McIntyre, and I am the chair of the Nursing Research Interest Group at RNAO. This virtual webinar series was initiated to share and promote nursing research and scholarship, both within the research community and across the broader nursing community. And in these sessions, our speakers profile innovative research being conducted across academic and community settings and address how their work can inform transformative change in practice, education, and policy. So our speaker will present for approximately 30 to 45 minutes, and this will be followed by some time to take questions. We encourage you to add any questions or comments you have in the chat box so that our speaker can address them at the end. And note that today's session will be recorded. So before we begin today, I'd like to acknowledge that here where I am situated, we learn upon the traditional lands of the Anishinaabeg, Haudenosaunee, Lenape-Wauk, and Chonokton nations. Today's scholarship speaker is Dr. Salima Sulaiman, an assistant professor from Brock University. And we sincerely thank you for being here today. And with that, I will pass it over to you.
Thank you so much, Amanda, for the introduction. And my special thanks to the Research Interest Group for providing me an opportunity to talk about my research. So in today's presentation, I will present the overview of my study's background and significance. I will outline my research design, study methodology. I will share the findings of my study, and then at the end, I will discuss the strengths and limitations, followed by the implication for future research. So before starting my presentation, I want to share my background to give you a sense of where I'm coming from and how I develop interest in maternal mental health in low and middle income country. The short form that I will use for this low and middle income country would be LMIAC. So during my BSc training, I developed an interest in women's mental health and mental illness during my community health nursing clinical rotation when I cared for several women suffering from depression and stress and anxiety. While these illnesses were preventable, but obviously as a new graduate nurse, the main focus was on patient care. So I started my career as a registered nurse. But I always wanted to work in this area, and therefore I decided to pursue master's degree to learn more about these issues. And this was an opportunity for me to place myself in a mental health area. So I decided to work on postpartum depression. In my master's thesis, I identified the prevalence rate of postpartum depression in mothers of term infants and mothers of preterm infants. Preterm birth is a risk factor of postpartum depression and is a burden in low and middle income countries. Worldwide statistics indicate most preterm births occur in Asia and Africa. In addition, the prevalence of postpartum depression is also high in Asia, especially Pakistan has the highest prevalence rate of postpartum depression. Hence, preterm birth could be one of the reasons for the higher prevalence rate of postpartum depression in Pakistan. To identify the prevalence in two groups of moms, a cohort study design was used, and group of mothers of term infants and mothers of preterm infants from Pakistan completed the depression questionnaire. The study found that the rate of postpartum depression was higher in mothers of preterm infants, which was 35.3%, than in mothers of term infant, which was 15%. So it's significantly, it's doubled the prevalence rate in the mothers of preterm infant. And significantly, the important finding were that depressed mothers of preterm infants indicated that they did not receive some level of support from their partner. And this was, I would say, this was the trigger point for me to work on this area to strengthen partner support for women around this postpartum period. So in my doctoral thesis project, I chose this area to work on and implemented a pilot randomized controlled trial to strengthen partner support around postpartum period, which I am going to discuss today. So what is postpartum depression? Postpartum depression is a condition that often exhibits the disabling symptoms of dysphoria, emotional lability, insomnia, confusion, anxiety, guilt, and suicidal ideation. Globally, the prevalence of postpartum depression reported to be 17%. But the comparison of high-income country and low-income country comes, LMIAC reports particularly high rates of postpartum depression. It stands at 20% compared to high-income country that reported the prevalence rate of 15%. In Pakistan particularly, the pooled prevalence of postpartum depression is estimated to be alarming high at 30%. And this 30%, if I compare with the LMIAC, the prevalence rate of LMIAC is quite high, like 20% and 30%. Is definitely the prevalence rate of postpartum depression in Pakistan is higher among the LMIAC country. And this may be because in Pakistan, the mental resources are limited. There is a poor healthcare infrastructure, lack of awareness in people regarding postpartum depression, or lack of acceptance of mental illness due to maybe stigma. So during the postpartum time, the existence of anxiety is also common in women. And worldwide statistics shows that 15% women experience postnatal anxiety. But when I compared the prevalence of anxiety between LMIC and HIC country, then the definitely high-income country shows the higher rates of anxiety in women, reported to be 19%, reported to be 34% compared to HIC, which is 19%. It's almost double. So based on these criteria, I included the depression and the anxiety rate in my study. If we talk about the consequences, so postpartum depression has well-documented negative consequences that impact the whole family. Depressed women provide inadequate care to their child. For example, women are less likely to have their infant use the back sleep positions, to use a car seat, and to have a working smoke alarm in the home. The relationship between mother and infant is also affected. For example, depressed women are found to be more irritable, to be less engaged, to exhibit less emotion and warmth, and to exhibit lower rates of play with their kids, with their infants. As a result, infants with depressed women are at risk of poor developmental outcomes. Significantly, it is related to the higher levels of behavioral, cognitive, emotional, and developmental problems in children. Partners, on the other hand, experience decrease in positive attitude towards sex and satisfaction with marital relationship and lower quality of life. So a consistent risk factor for postpartum depression that is identified in the literature is the lack of partner support. So the definition of partner that I referred in the operational definition in my study was husbands or male domestic partner with whom a woman share a sexual and economic partnership, even though they are not married. Partners factor during the transition to parenthood are modifiable factors that can significantly decrease maternal depressive symptoms. Meta-analysis identified factors such as communication, conflict management, relationship satisfaction. These are the modifiable factors that can protect against depression. And the supportive relationship with the partner helps women mitigate the stressors of being a new mother. Meta-analysis revealed the male involvement at postpartum period significantly decreases the likelihood of postpartum depression by 66%. If you look at the literature available on the partner-inclusive interventions, so partner-inclusive interventions have demonstrated beneficial preventive outcomes for postpartum depression, definitely. But despite this fact, none of the studies in Pakistan has focused on using partner support to prevent postpartum depression in women. Only one partner-inclusive randomized controlled trial was found in Pakistan, and that was done to reduce maternal and neonatal mortality, not related to the postpartum depression. And this trial found significant reduction in the early neonatal mortality rate. So therefore, it is possible that partner support will have an impact on maternal postpartum depression, because so far there is no study that has been used this partner support strategy to reduce postpartum depression. So the hypothesis may be it is helpful, like it may reduce the risk of postpartum depression in women. So in this particular study, I used co-parenting intervention. So co-parenting intervention was pilot tested in this study. And there were several reasons for choosing this specific co-parenting intervention. First of all, it is a tested intervention and it is based on modifiable factors. Also, several positive outcomes have been achieved for partners and infants, for parents and infants through this co-parenting intervention in different studies. Additionally, the co-parenting intervention has been adopted and tested in diverse culture and shows a mixed finding. For example, like with German and Japanese populations, the co-parenting intervention has found positive findings on some co-parenting relationship aspects, such as less conflict in couple, whereas no significant difference was found in parents' level of depressive symptoms. In USA, with co-parenting intervention in another trial, parents' postpartum depression was reduced. And in a recent trial with a low-income couple in USA, a significant effect on mother's depressive symptom was found, whereas no effect was found on father's depression. Therefore, there was a need to test the effect of co-parenting trial in the context of low and middle income country, as none of the study has tested co-parenting intervention or any sort of partner support intervention. Another reason for me to choose this intervention is that it is well supported by a co-parenting framework. Now let's talk about the study methodology. So the study objectives were, the primary purposes were of the study of this study was to examine the feasibility and acceptability of the co-parenting intervention trial. The secondary purpose of this study was to evaluate the effect of the intervention to reduce the risk of postpartum depression among primiparous Pakistani women. A single center pilot randomized control trial was used in this study, and outcome data was collected by a research assistant, blinding to participants' group allocation. Couples were recruited from a tertiary care hospital from Karachi, Pakistan in the first and second trimester of pregnancy and randomized to either in the intervention group or the control group. The sample size was 106 couples, and these couples were recruited from Karachi, Pakistan, a tertiary care hospital. Couples were eligible to participate in the study if they were primiparous, both women and their partners willing to participate and indicated by signed consent. Up to 24 weeks of gestation, singleton pregnancy, able to speak, read, and understand English or Urdu, and have an access to internet, because this was an online intervention. Couples were excluded if women scored EPDS, scored greater than 12 on EPDS score. So EPDS is a tool which I used to recruit participants at the time of recruitment, and I also use this. This is a depression scale, which I will discuss later on. And mothers, like husband and wife, they both completed this depression tool, EPDS tool, at the time at 4 to 6 weeks and 12 weeks postpartum. As I said, I use the co-parenting intervention, but what is this intervention, right? This question arises. So the purpose of this co-parenting intervention was focused on developing conflict management, problem solving, communication, and mutual support to foster positive joint parenting of an infant. So the purpose is to prepare couples for the challenges, for the upcoming challenges when the infant will be here, and then for the smooth transition, so they learn the basic skills at how to communicate and less conflict and all those things, so they better prepare themselves for the transition to parenthood. And this intervention has actually 8 videos to be completed during antenatal period only. And these videos were 30 to 40 minutes each. The website was developed and all the videos were uploaded on the website, and the website was password protected. And only the specific password was created for each participant and was shared with the participant at the time of recruitment, once they were randomized to the intervention group. And these videos were actually in English, but Urdu subtitles were added. And this video, this intervention or this video comes with a workbook, which has activity, it is an activity-based workbook, and it has activities, it has pictorial things, it has discussion questions, and all those things to facilitate the discussion between the couples. And there were activities integrated in the videos. So couples were during that interactive videos, the couples were asked to complete the activity. So the empty pages were there, and all those, the facilitated questions were there in the workbook. And couples were asked to complete this workbook while watching the videos. Yeah, this was all about the intervention, and couples were asked to watch one video per week. So the primary outcome measure of the study was feasibility and acceptability. Under the feasibility, the participants' eligibility rate and enrollment rate were measured, and adherence rate was examined. So adherence actually included the adherence to the intervention material and completion of a co-parenting workbook, both things. For acceptability, couples' perceptions and satisfaction regarding the intervention was measured through satisfaction form. For secondary outcomes, to measure depression, the EPDS tool was used. To measure anxiety, state, trait, anxiety inventory was used. To measure co-parenting relationship scale was used. And to measure relationship satisfaction, revised IDEC adjustment scale was used. These all scales are reliable, are valid tools, and then their reliability and the psychometric properties is measured. They are valid instruments that I use in my study and has been used in the previous studies with this postpartum women. Regarding data analysis, I used the descriptive statistics and t-test and chi-square test. When I talk about the results for couple recruitment, in total 771 women were assessed for eligibility, of which 254, that makes 41.3%, met the inclusion criteria. So the eligibility rate was 41.3%. And the most common reason the participants were not eligible to participate in my study were the partners were not present at the time of recruitment, because this was one of the eligibility criteria that the male partner should be there. So those women whose husbands were not there at the time, they were not able to participate in my study. And the other reason was the women scored greater than 12 on EPJS score. That was the exclusion criteria. Out of this 254 eligible women, 42 couples declined participation. So the enrollment rate from eligible participant for this pilot study was 83.5%, which was fair enough and was quite big in number. So the most common reason for declining participation, but couples were not interested and they were too busy with their commitment. Adherence rate, that was the second primary purpose of this study. Altogether, 24 couples complete, sorry, this is the acceptability. Yeah, so for acceptability, no, I missed one thing. So that's the adherence rate. Yeah, I talked about eligibility and adherence rate. So the adherence rate was measured through the completion of videos and the workbook. So altogether, 24 couples completed the required intervention dosage of at least 5 videos, which was very less. And the reasons given for non-compliance were lack of time, availability of videos for shorter duration, because the intervention was only offered at antenatal time period. And in the postnatal period, women and couples were not able to access to these videos because they were meant to complete during antenatal time period. The videos were long. As I said, it was 30 to 45 minutes duration. So the couples find it very long videos, and they were having some internet issues because of the speed, the availability of the internet speed at that home, which was very slow, and the videos were taking longer to download. So they were having difficulty in accessing the videos at that time. And participants were not interested to watch the videos even, because some of the participants, they did not go on the website and watch any videos. They not even enter onto the website. And the reasons given that they were not interested to participate, to watch the videos. Participants, and then during the, this forms and data collection or outcome measurement, I also asked if they have any recommendations or any suggestions to improve the intervention. So participants recommended to provide videos for longer period. They wanted to provide this video during the postnatal period as well, along with the antenatal period. So they wanted a longer time period to watch these videos. And they propose some video-related changes. For example, they want some changes in the content. Like they want the videos to be included culturally specific content of their culture that reflect the culture, traditional culture of their society. And the other recommendation that was proposed by the participant was provide internet-friendly videos that run smoothly and that have fast download speed. This was all about the intervention. When I measured the completion rate of booklet, so only 37 couples completed some or all activities of the workbook. And the reasons given for non-completion, that they lost the book, they forget to complete it while watching the videos. So these were some of the common, and they had lack of time. So these are some of the reasons for not completing the workbook. If I talk about the acceptability, so items on the intervention satisfaction form, I use the satisfaction form to ask their perception regarding the intervention. And this was the form that I used, and that were grouped under 4 themes: co-parenting content, applicability in daily life, intervention feasibility, and general satisfaction. Only a subgroup of couples in the intervention group, that is only 24 couples who completed the required intervention dosage, completed this questionnaire. So only, out of 24 couples, 22 couples felt the content of the videos was helpful and provided appropriate strategies for managing situations or problems. If I talk about the secondary outcomes, so the first outcome, secondary outcome, was depressive symptomatology. But before I start, discussing the result of what this secondary outcomes, let me just tell you that the couples completed the depression and anxiety scales at both time period, that is at 4 to 6 weeks and 12 weeks postpartum. Whereas all other tools, they only completed at 12 weeks time period. So only completed once during this study. So depression was completed at both time period, 4 to 6 weeks and 12 weeks. So no significant difference were found in depressive symptomatology between the intervention and control group among women and partners at 4 to 6 weeks and 12 weeks postpartum. However, at 4 to 6 weeks, less women and partners in the intervention group demonstrated depressive symptomatology. Similar trend was observed for partners at 12 weeks postpartum. In terms of anxiety symptoms, no significant difference in anxiety levels were observed between the intervention group and control group among women and their partners at 4 to 6 weeks and 12 weeks postpartum. However, partner in the intervention group shows a trend of declining anxiety at both time period. When I talk about the other two outcome, that is a relationship satisfaction, they only completed it 12 weeks. So no significant difference was found in relationship satisfaction scores between the intervention and control group among women and partner. However, less partner in the intervention group experienced relationship dissatisfaction. Co-parenting relationship, so no difference, again, is found in mean total scores of co-parenting relationship for women and partner between intervention and control group. However, the total mean score for partners co-parenting relationship was higher for intervention group than for the control group. So these were the, the summarization of my study findings. Now I'll talk about the study strength. The study was used well-described eligibility criteria for participants. And to prevent the selection bias, the randomization process was done, and sequentially numbered opaque sealed envelope were used to randomize the participant into the intervention group and to the control group. And which were these envelopes were made by the research assistant who was not involved in this study. The questionnaire had high validity and reliability and were translated and pilot tested in the local language. In addition, the intervention was delivered through a password-protected website, which was not available publicly. Lastly, the research assistant who collected outcome data was blinded to group allocation. So the research assistant, she was not involved in in making the envelopes. She was not involved in the recruitment of participants. So she was another research assistant who was, completing the outcome assessors, who was completing the outcome measures from the participants. There were some limitations of the study, such as the use of self-reported questionnaires. Though the questionnaires instruments have good psychometric properties, however, the nature of self-reporting increases the potential for response bias. The intervention satisfaction form was completed by a subgroup of couple who completed the intervention dosage. That is only 24 couples, not 106 couple. And this limits the understanding of the perception of intervention content overall. Lastly, the participant in the study may have some sort of supporting relationship exist beforehand and before this study, because one of the criteria of recruiting participant is that the male partner should be present with women at the time of recruitment. So maybe they have already, sort of a supportive relationship exists between them. Therefore, the male partner was there. So therefore, the finding need to be used cautiously. Implication, because this was a pilot randomized control trial, and the very few couple completed the intervention dosage. So then I only provide the implication for the research. So to specifically understand the required intervention modification, mixed method study is recommended in the context of Pakistan to explore parental perceptions about co-parenting and how best to deliver the intervention when next time it would be, applied. So yeah, this is all about my research, and thank you.
Thank you very much, Salima. That was wonderful. Really great work. Really, really great work. Did anyone on the call have any questions for Salima? That's okay. Salima, before we get off the call, I was just wondering if you could, I was wondering if you could clarify when you started at Brock as an assistant professor and sort of where you see the trajectory of your work going.
Yeah, excellent question. So I started my PhD in 2015, and then I defended in 2021. And since then, I joined Brock. So from 2021 July, I started my job at Brock University. And this is, one of my favorite area. And this is what I want to, apply, because applying the transformation of this knowledge is very well there in the immigrant population. So currently, and this is my aim, that to look for or to assess the partner support that is provided in the Canadian immigrant population, and to see how I can improve that partner support in immigrant population, because they are from the minority status in Canada, and they are coming from the developing country where the culture is almost same, which actually I already explored and I found in these my previous studies. So the culture is almost same, that males are there, but they need some support and training, maybe to support their wife. So this is what my aim is. And then in my recent research, which I got a grant for that, and it's ready to apply, and then it's under the RAB board. And in that research, I'm trying to identify the association of co-parenting relationship with immigrant population, minority immigrant population. So this is proposal is complete, is already completed and under the RAB board, and I got the grant for this. So I'm just waiting to, start working on this research. And furthermore, my other research is, which I'm also, developing right now. The focus is again the partner support. How do women cope with this new culture when they come here? So what are their coping strategies? How do I help them, those partners, to come to forward together and help each other in this transition to parenthood journey.
Mhm.
So that's my
That's fantastic.
idea. Yeah.
Well, congratulations on your grants, and I wish you luck with your ethics board approval. Some of your work just sort of works alongside or in similar veins as Dr. Shokafe or Faye Mondalou here at Western, who's also a new tenure track. So yeah, some of the overlap there. I don't know if you've worked in collaboration with her before, but there might be some potential there in the future. So yeah, that's excellent. So I just want to thank you again for coming to speak for NRIG for our monthly webinar. We really appreciate it.
Thank you so much for providing me this opportunity.